I'm Earl Walker, and interviewing Dr. Orlando Andy, who has had a very interesting career. Dr. Andy, would you like to tell us a little bit about your educational career and titles that you have and so forth at this time?
Yes. I went to University of Rochester School of Medicine, and from there I went to Hartford, Connecticut at St. Francis Hospital for a rotating internship, and then served in the armed services as a surgery assistant and assistant in a pathology lab for a couple of years. And from there went into neurosurgical residency at Memphis with Dr. Semmes and Murphey, and then went to Johns Hopkins to train with Dr. Walker.
Well, I recall very well your time with us, and I've followed your career with much interest. It seems to me that you have had a remarkable experience, and I just wonder if in this exciting career that you have had, if you would like to tell us something of the perhaps the outstanding events that have happened, the ones that strike you as being most interesting perhaps, or perhaps having the greatest effect upon you in your subsequent life.
Well, some of the greatest events that have happened from the beginning, first of all, was at the University of Tennessee, where I came in contact with a patient with complex partial seizures who went into status and finally died. And I was eager to find out more about complex partial seizures, and that set my goal for my future work in general. The next thing that happened was going to Dr. Percival Bailey's laboratory and studying under his protection and guidance, and being exposed to Dr. McCulloch and Dr. Gibbs and others in the laboratory, and learned a little bit about pathology. And my next step was to go to Hopkins, where I really got into learning more about the brain in relation to seizure propagation systems related to behavior.
Now, when you were with Dr. Bailey at the University of Illinois, I presume, what opportunities did you have to work with Dr. Bailey and to see his laboratory and get acquainted with him?
Yes, I got acquainted with Dr. Bailey and worked in his laboratory. I worked on the pathology that he had going through his lab, in addition to working on the pathology that he had from irradiated monkeys being...
Well, can you tell us a little bit more about, the personality of Dr. Bailey? And
Dr. Bailey was a very deep individual. He liked to philosophize quite a bit, and had his own mind in thinking about various factors that he would discuss, and also allowed you to do your own thinking and encourage you, in fact, to be independent in whatever you did.
Well, now, while you were there, you met a number of other people as well. Were any of those outstanding as far as you were concerned?
Yes.
Played much of a role in your life?
Dr. Lichtenstein. He was an excellent teacher who taught me a great deal about neuropathology, and made it especially interesting because he brought in behavioral changes associated with the pathology.
This is Dr. Ben Lichtenstein.
Dr. Ben Lichtenstein.
Yeah. And were there any other men at that time who had a good interest on you?
Dr. Gibbs and his wife. I would sit down at the table with them while they were watching and reading EEGs. And it was just like going through a history of a patient just from looking at the EEG.
And tell us about Dr. Gibbs and his wife.
They were very hardworking and appeared to work very well together, and very considerate and extremely concerned about what they were doing, and spent much more time on their work than many others did.
And were they particularly interested in certain aspects of epilepsy?
They were interested in petit mal and in complex partial seizures, and tried to relate seizure patterns to various types of behavior, and actually described many behaviors and assigned those behaviors certain type of patterns. He also published several volumes of text on seizure patterns and behavior.
Well, let's go back a little bit to your early education. Where were you educated in public and high school?
I was educated at New Britain High School in New Britain, Connecticut, and then at that time was very interested in football and played quite a bit of football and sports in general. And from there I went to Ohio University, and at Ohio University I was primarily interested in dentistry. And after my first year in dentistry, a couple of students, fellow students, and then a professor I had with respect to a course in comparative embryology of the nervous system by Rush Elliott, I became interested in the nervous system.
Well, now, tell us, who was Rush Elliott?
He was a professor of biology at the Ohio University in Athens, Ohio. And he was an in-depth type of anatomist and comparative anatomist, dealing primarily with the nervous system of the cat. And
how did you come to get interested in medicine? Were your folks physicians or interested in the medical field?
No, my folks were not physicians. I got interested in medicine through a dentist that I used to go to. I originally had intended to go into dentistry and work with this particular dentist, but then I told him I got interested in nervous system, so I changed.
Well, now, what did your folks do? Your father, for example, what was his occupation?
My father was a laborer, and he worked for the New Britain Gas and Light Company, and started out as a laborer on the road, and then went to being a repairman for the gas meters that they used to use at that time. He also liked to invent little things and gadgets of various types.
And your mother, had she special interests?
My mother did not have any special interests. She was primarily a house mother.
And had you any brothers or sisters?
No brothers, no sisters. A grandfather and an uncle. My mother's brother lived with us.
So you went to Ohio University then?
Yes.
And did you get a degree from there?
A BS degree.
Yes, degree. And from there, you decided to go into medicine?
Yes.
Tell me, why did you become interested in the field of medicine?
I think I became interested in medicine, first of all, because I was interested in the nervous system, and second because I had a feeling for people. I liked to help, and illnesses in general always interested me to some extent.
And you didn't go to Ohio University for your medical training, though. You went to Rochester, as I understand it. Is that?
Rochester, New York.
Why?
Yes.
Why did you choose Rochester? There were a number of other excellent schools nearby.
Yeah, I applied to Cincinnati, Western Reserve, Chicago, and Rochester. I got an acceptance from them. And I chose Rochester because, number one, the dean was Dean Whipple, just got his Nobel Prize, and he had collected a group of professors to initiate the Rochester School of Medicine with some very excellent talent. And the second factor was that they had a lot of money.
Well, that's very important these days. And what of your professors at Rochester had a great impression upon you?
First of all, Dean Whipple himself, a very philosophical man, very deep. His first announcement when we all arrived was, we've chosen you to go to medical school. We know that you will finish, and all you have to do is your work. And our teaching system was very nice in that they gave an exam periodically. You never knew where you stood unless you were behind. Then they'd send you a little yellow slip.
Well, now, were there other physicians there that had a great influence upon you?
Dr. Wilbur K Smith, who taught us histology, was working on the chimpanzee and monkeys and stimulating the cingulate gyrus when I was there.
And did you work with him on that?
No, I just watched.
And were there other men there as well?
There were others. I worked with a Dr. Strain, who was from Eastman School of Kodak.
And he's the Dr. Strain who put together Pantopig. Is that?
That's right.
And were you associated with that work?
Yes, I worked on the dogs that were used experimentally to develop that, and would inject the drug in the spine, and then make sections of the spinal cord and other parts of the brain. And Dr. Whipple was the one doing the pathology, and I got a great deal out of that with Dr. Whipple.
And did you do any further work with Dr. Strain or with Dr. Whipple?
No, that was all I did with them. And
well, now, how did you come to get interested in neurosurgery there? These men were in basic science.
I was actually interested in neurosurgery before I got there. I decided to become a neurosurgeon when I was at Ohio University under Dr. Rush Elliott, who was showing us the various parts of the nervous system, would draw these long lines from the brain to other parts of the body, and it just fascinated me.
Well, who were the neurosurgeons that you met at Rochester?
Dr. Jack French was the neurosurgeon at that time. He had finished his residency there and was temporary neurosurgeon while Dr. Van Wagenen was in the service.
Did you know Dr. Van Wagenen?
I did not know him personally. He was not there when I arrived.
And what about Dr. French?
I know him, yes.
And can you tell us a little about him? Your contacts?
Dr. French was a very excellent neurosurgeon, very good with the patients, and excellent teacher. On one occasion, I'll never forget having seen a patient with him and looking forward to it. I was in my 4th year. He changed the dressing, and I was eager to see my first neurosurgical case. And there was so much blood on the scalp, I became sick, left the room, and then I had something leave me too.
Well, that wasn't uncommon in those days, was it?
That's right.
Well, now, what further experiences did you have while at Rochester?
I had some experiences in the lab again, primarily with Dr. Kochakian, who had a course on vital economics in which he had us perform various experiments, and I recall I picked down the adrenal gland and looked at the various steroids that were implicated there.
Well, now, after your work, you got your degree
Yeah.
at Rochester. Then where did you go?
I then went to St. Francis Hospital in Hartford, Connecticut, and I went there because of Dr. Buckley. He was a neurosurgeon who had trained under Cushing.
And can you tell us a little bit about him?
Dr. Buckley was the neurosurgeon in that part of New England. This was in Hartford, Connecticut, for quite a few years, and had had a very large practice, anywhere from 40, 50 patients at times, and treated all types of conditions that had to do with pain or brain tumors and other disorders that came under the aegis of.
And were you on the neurosurgical service?
I was on his
Hartford,
neurosurgical service as an intern.
I see. And then what happened after that?
I then finished my internship and went into the service. I went to Pineville, Louisiana, a government hospital where they treated a great deal of tuberculosis and had a lot of surgery in general.
Any neurosurgery?
No neurosurgery, just general surgery.
And after your stint in the Army, where did you go?
I went to Semmes Murphey Clinic in Memphis at the University of Tennessee. This is Dr. Murphy, Dr. Semmes, Dr. Schultz, Dr. Desessor. And there I am in the back with two other residents.
And how did you happen to go there? This is quite a ways away from Rochester and where you were brought up.
My objective was to get a neurosurgical training at a large service. So I made a tour of the country, starting at the East Coast, came down the southeast, went to New Orleans, looked at the large hospital they had there, and then went through Semmes Clinic, went to Mayo's Clinic, and then New York. And of all the clinics, I felt that Dr. Semmes' clinic would give me what I was looking for.
Oh, that's very high praise for the Semmes group. And what was your experience there?
It was a tremendous experience with respect to general neurosurgery, just across the board. And they had as many as 50, 60 patients in the hospital at the same time. And it covered neurology also in many instances, in addition to neurosurgery. And I had a great deal of experience at the operating table. And at the John Gaston Hospital, which was the service hospital for that particular community, we saw all types of pathology. I worked day and night.
You spoke of the pathology there. This was the clinical pathology from your operative cases,
Yes.
not autopsy work.
Yes. And also pathology to work on.
I see. And for how long were you there?
I was there for 3 to 4 years. I spent part of my time away and then went back.
Where did you go?
I went to, for example, at Illinois with Dr. Bailey.
That's when you were with Dr. Bailey
yes.
and the group there. And then after that?
Then I decided to pursue my desire to learn more about complex partial seizures in general and behavior. And I approached you for a job.
Uh-huh. And then how long were you with us?
That was for a period of 3 years.
And during that time, what were you doing?
I spent most of my time in the laboratory working with cats and monkeys. First of all, working with Dr. Hackett on the cats, stimulating subcortical structures and cortical structures, trying to determine the communication between these various areas of the brain with one another.
And Dr. Hackett was from Europe?
Dr. Hackett was from Europe, and he was a student of Dr. Hess, who had won the Nobel Prize with the technique and the findings that he had made in Zurich.
And so that was the technique that you were using at Hopkins, or essentially.
Yes, I was very fortunate to work with Dr. Hackett because he had Hess's technique, which consisted of bipolar stimulation and recording into the depths of the brain.
Mm-hmm. And then where'd you go from there?
Well, I actually left Hopkins and came to Mississippi. But I must say that while I was there, I also worked with you and other associates in the laboratory, and really got my major push from your activities with respect to trying to trace propagation of seizures from one point to another, and especially with respect to trying to explain various types of behavior that may originate from cortical discharges or subcortical discharges.
And
I then came to Mississippi. And
how did you come to go to Mississippi?
That's interesting. You may or may not remember, I was destined to go to France. I think there was a job available in France where they wanted a lab, something like what you had, and I was thinking about going over there. And when they called from Mississippi, I said, well, I'm not interested because I don't think I can get done what I want to do in Mississippi. And they called back several times, and I finally talked to you, and you said, well, Andy, you have to settle down sometime. So I thought, well, I'll go down and take a look. And I did take a look. And I met Dr. Guyton and Dr. Hardy, who were very strong researchers and I thought would be very supportive in types of activity I'd like to get into.
And so you accepted the position here?
I accepted the position. And I looked
Well, had there been a neurosurgical service here prior to that time, or were you initiating the program?
I was actually initiating it. The medical clinical school was new, just built.
And did you have a training program?
I had a training program which was both clinical and laboratory. In the laboratory, I initiated a postdoctoral program in physiological psychology, and did that in conjunction with Dr. Wolf, who was at Oxford. And Dr. Wolf was trained at Yale under Fulton, and he had a great deal of interest in behavior and had a lot of experience with monkeys.
Well, now, did you have some clinical neurosurgeons working with you here at the university?
I arrived with a psychologist as my first associate, and everyone wondered what I was doing and where was my assistant neurosurgeon. I didn't acquire one until several months or a year or so later, and then got the clinical service running. But before then, Dr. Charles Neal, who was a clinician in town, was my major associate. We also didn't have patients for a while, and he would just hire an ambulance to carry patients from his private hospital over to the university so we can use for teaching.
So your clinical work was then done in collaboration with Dr. Neal?
Yes.
And Were there any other associates here with you? Anybody in the field of, let's say, neurology or electroencephalography?
At first, there were none. I was the neuroscientist, so to speak. We didn't have any EEG, had no neurologist. I finally got Dr. Marion Jerko to work with us in clinical electrophysiology, and we also got a clinical neurologist then. This is Dr. Marion Jerko. She came to our department in the 50s. Together, we worked on clinical problems with respect to behavioral changes and electrophysiological changes. She was an electrophysiological psychologist. This is Dr. Fauché. He came to us in 1950s and was the chief of our laboratory of experimental behavior. This is Dudley Peeler. He was in the program when Dr. Fauché was head of it, and later became the chief after Dr. Fauché left. This is Fred Sias. He is an electronic engineer who assisted us in developing our various techniques in the laboratory and also in a clinical setting for making lesions and for stimulating and recording.
And what were Dr. Jerko's interests?
Dr. Jerko was a clinical physiological psychologist, primarily, interested in electrophysiology and behavior. And
did you have a research program with him?
Dr. Jerko, yes. She was excellent in analyzing various types of behavioral disorders in patients, and also had an excellent background in electroencephalography. We worked a great deal together, trying to correlate behavior with various types of electropathology of the nervous system.
Well, now, tell us in general about your research program at that time.
At that time, it was primarily built around Parkinson, tremor, and rigidity. Clinically, we tried to correlate the location of a thalamic lesion to treat Parkinson tremor with the size of the lesion and also the electrical activity. We looked at various types of tremors that could be activated at that level by stimulation.
And what did you find?
We found that the optimum site for us was in the subthalamic area and called it subthalamotomy. In correlating our findings with those of Cooper and others made me conclude that the optimum site was at the inferior border of the thalamus, at the rim. This is a photograph taken from Neurosurgery Journal in the 1960s of a subthalamic lesion placement site for the treatment of Parkinson's tremor. We were very active for quite a few years at that time, placing lesions in the subthalamic area for the treatment of Parkinson's tremor and rigidity.
So you were making your lesions a little lower in the thalamus than most of the other surgeons at that time.
Yes, and not as large.
And not as large.
That's right.
Mm-hmm.
I was closer to Spiegel and Weiss's location than to Cooper's.
Mm-hmm. And did you have any other research interests?
We had other research interests in the line of seizures, especially with respect to amygdalotomy. In those patients, we used amygdalotomy rather than temporal lobectomies in order to treat complex partial seizures that were intractable. The reason I didn't like temporal lobectomy was I was getting rid of tissue which in part was normal, and I was trying to get to the actual site of the generated abnormal discharges.
Well, now, do you have some reprints on that work?
Yes, I do. I don't have any exposed right at this moment, but we have reprints in which I've done a combined amygdalotomy and thalamotomy,
Yes.
and also have a reprint on amygdalotomy for psychopathic behavior, thalamotomy for psychopathic behavior. This is a publication on bilateral amygdalotomy for temporal lobe seizures. It's a study performed by Dr. Marion Jericho and myself and Dr. John Hughes, who was coming down here from Northwestern in order to perform studies on the amygdala and olfactory responses to various odors. These clinical studies impressed me with the fact that the amygdala, in all probability, was a link between the cortex and brainstem structures. In the 1970s, we published a case with psychomotor psychic seizures treated with bilateral amygdalotomy and bilateral orbitotomy. These are spike discharges in the amygdala. Note the relative absence of discharges in the scalp.
Well, now, how did you happen to get into the psychopathic behavior?
During the process of treating some of the patients with amygdalotomy for complex partial seizures, there are many patients who had aggressive behavior, or they were hypersexual or hyposexual. After amygdalotomy, those behaviors would be restored to a more normal state. In some of the patients who had a combination of major motor seizures and complex partial seizures, I performed a thalamotomy in addition in some of those patients in order to prevent or control the major motor seizures.
Well, now, at that time, there was considerable feeling in the medical profession about operations to modify behavior and modify the mind. Did that affect you at all?
Yes, it did.
You were working in that field. And
Yes, it did very much. And the way it affected me was I was reporting on behavioral changes that would result from these various lesions and trying to point out how they could improve, even if you were treating a patient with complex partial seizures or some other problem. When I then recommended some of these procedures for treatment of aggression per se, and not necessarily associated with complex partial seizures, it was not very well accepted.
well, what do you mean?
It wasn't accepted because they were actually stating that I was modifying people's minds and changing how they were going to believe, and I was accused of probably get our governor and put something in his brain and make him do things that I wanted him to do, say. All types of accusations that were sort of ridiculous.
Well, was there much reaction on the part of the politicians to your work?
Yes. The central government got involved. For example, I had given a paper, Dr. Earl and I gave a paper on thalamotomy for the hyperactive syndrome, which was a combination of hyperactivity and aggressive behavior with also psychopathic behavior in some instances and some instances not. In 1972, we published a paper on focal thalamic discharges with visceral disturbances and pain treated by thalamotomy. This was a very exciting finding because it demonstrates a 14 per second discharge with a reversal at that point in the sagittal plane of the thalamus along the lamina medullaris interna. You can see that this was the entire extent of the discharge with the reversal approximately at that level. We made a lesion at this area. A psychiatrist by the name of Breggins at that time picked up and went to a meeting in Europe that the Psychosurgery Society had, and I presented the papers there, my papers there, and others presented papers on frontal lobotomy and so on, and other types of approaches. And he then came back to this country and started saying that we were doing psychosurgery in Mississippi, just like others were doing in other parts of the country and throughout the world. And he started more or less a wave against psychosurgery in general. Anything that had to do with a surgical procedure that modified behavior, whether it be restored or improved or worsened, was called psychosurgery.
And what happened?
They actually stopped psychosurgery 100%. And as far as I was concerned, in our country, I was involved with having to appear at a hearing that Kennedy had when he was head of the health department.
And do you have to give up your program?
Yes. After that hearing, they stopped all psychosurgery, and we couldn't do any more surgery for aggressive behavior and psychopathic behavior.
Well, now, what happened after that?
After that, we just continued with treating Parkinson's patients and patients with pain, and not patients with hyperactive syndrome, in other words. And we continued to treat patients who had complex partial seizures, but not get involved with the behavioral aspects of it.
Mm-hmm. Well, now, do you have some papers? I noticed a number here on that subject.
In chronic pain, yes.
Yes, or hyperactive syndromes?
Hyperactive syndrome. I don't have it right here with me, but I can go into that. This is a case report of a 20-year-old patient who had seizures and pain. She first started having seizures at 3 years of age. She had brief shooting pains, and from age 13 to age 20, they increased with respect to the number of body parts that were being included in time. Note how they started with a few body parts and gradually implicated more and more up to the age of 20. The patient presently has a stimulation electrode in the thalamus placed at the level of the central medianum nucleus, as revealed here in the sagittal plane. It has been effectively controlling the pain for the past 9 to 10 years. This is Chronic Pain as a Reticular Formation Syndrome, a publication in the Pavlovian Journal, 1986. The reticular formation extends from the caudal medulla up through the brainstem into the thalamus and hypothalamus. It is for that reason that I identify chronic pain as a reticular formation syndrome. Note that the fiber system carrying pain runs in this area and sends off collaterals into the reticular formation as it proceeds up to the thalamus. It is those collaterals which supply the reticular formation with the pain impulses. And the reticular formation is responsible for the pain that the patient experiences. In addition, there are other body systems that are represented in the reticular formation. For example, the medullary area contains the cardiovascular system, The respiratory system also is located in this area. We have the sleep system at this level, control of eye movements in this area, in addition to some of the long-tract extrapyramidal systems that originate at this level. Up above, there is control of temperature, sexual activity, eating and drinking is also controlled in this area. Electrolyte control is throughout this entire region. The aggressive system extends from the septum rostrally down through the hypothalamus into the periaqueductal area of the midbrain. This is diffusely represented. All of these systems are interconnected through the reticular formation. And that is the reason, again, for my identifying chronic pain as a multiple system syndrome. These are 4 patients diagrammatically represented in the reticular formation at the site of discharge. Case number 1 is a female who had chronic body pains in addition to headaches and had marked dermatographia. In addition, she had visceral problems. For example, she would eat a steak and within an hour defecate it. This represents the discharge that was found at this level of the thalamus of patient number 1. The medium-sized dots represent the extent of the reticular formation involvement in that case. The discharge spreads through the reticular system in order to involve various body parts. In 21 patients, a probability study was performed in order to determine the frequency of occurrence with respect to various systems in the chronic pain syndrome. As you will note, the chi-square analysis identified headache as occurring in over 75% of cases. In over 70% of cases, they had depression, motor system involvement, and headaches. In over 65% of cases, it was body pain, depression, motor, and headache. In over 60%, sleep, anxiety, body pain, depression, motor system, and headaches. In over 50%, sensory system, gastrointestinal system, sleep, anxiety, body pain, depression, motor system, and headache. Systems involved with a 50-50% probability are allergy, absence, speech, cerebellar, attempted suicide, vestibular, respiratory, cognition, aggression, vision, and memory. Those systems that are involved with less than 50% probability are impairment of consciousness, temperature changes, urinary involvement, cardiac involvement, stuttering, auditory system, sexual, olfactory, circulatory, crying, histamine reaction, agitativeness, lethargic, skin, and endocrine. Note that you have decreased number of systems that are implicated in less than 40% probability. And this is the group that is below 35% probability of occurrence: circulatory, crying, histamine, agitative, lethargic, skin, and endocrine. The systems that are involved in less than 30% of cases are histamine, agitative, lethargic, skin, and endocrine. As you can see, the chronic pain syndrome is not only a reticular formation syndrome, but it also may be called a multiple system syndrome.
Now, your work continued, and as I recall, didn't you get an award for that work?
Yes, I got an award from the Pavlovian Society. Now, this award was made in relation to a study that had been conducted in our laboratory demonstrating the development of hypersexuality in relation to slowly progressing seizures elicited in the limbic system.
Did you have any other awards of that nature?
I had an award here recently from a society in New Britain, Connecticut, and they awarded for humanitarian reasons, and I happen to be from that vicinity, and my father was a member of that society.
Oh, that's very nice. Well, now, what has your work been in the last few years? Have you continued along the same line that you outlined?
Yes, I have continued with respect to looking at the diencephalon and limbic system and behavior, both in the laboratory and clinically. In the past 10 years especially, I've been putting electrodes in the thalamus and using them for controlling pain by self-stimulation.
And can you tell us a little bit more about that work?
The patients who have chronic pain have been found to be relieved with a thalamic electrode implant.
And what part of the thalamus do you insert these electrodes?
It's in the area of the centromedianum nucleus. The reason for choosing that is that the laboratory work that we have been doing and also work that others have done seem to point to the reticular system as being the substrate for developing chronic pain. The general concept that I have formed in relation to my clinical and laboratory studies is as follows. The cortex represents the thinking brain. The brainstem represents the non-thinking brain. Note that the brainstem includes the diencephalon, hypothalamic area, pons, and medulla. The brainstem and the cortex are in balance, one with the other. In between the thinking cortex and the non-thinking brainstem is the limbic system. It forms a bridge between the two components. In my comparative studies of the brain, I was impressed by the phylogenetic consistency in the anatomic organization of the brainstem. In that organization, I have also included the rostral septal area, which makes up the rostral component of the axial brainstem. Note that in the study of the phylogenetic development of the primate septum, we compare the human, in this case, which has the same nuclei as the Zorex araneus, which represents a midpoint between insectivores and prosimians. This is a comparison of the limbic system between the human and Cercopithecus, which is a lower primate. The limbic system in this instance is right here. And forms a transition or a link between the cortex, the thinking brain, and the brainstem, the non-thinking brain, as previously mentioned.
And as I understand it, you insert electrodes in that region.
Yes.
And what do you see in the recordings in those patients?
We record during that time and find discharges. They're abnormal discharges.
Of what type?
A spike and wave could be alpha, theta frequencies, mostly theta and delta, and they come in bursts. They vary in amplitude also.
Now, are those bursts related to the pain?
the bursts are not directly related to the pain. In other words, there's no particular pain that goes with a particular burst. However, it's of interest that the pain which is generated at the brainstem level, from pathology at that level, as we have found in several patients, especially one that we've reported, are very quick and evanescent and sharp, just like tic douloureux. It's very interesting. That's one of the main things about brainstem-generated behavioral changes. They're very quick.
And are you able to relieve that by stimulating or making a lesion in the medial thalamus?
Yes. First of all, we started out making lesions in the thalamus in 1960 or so, and lesions in the area of the central medianum nucleus would alleviate pain for a period of approximately 6 months or so, and then the pain would slowly return. My first exposure to using stimulation for the relief occurred while I was in the process of recording and stimulating in preparation for making a lesion. And I recall the patient under local anesthesia telling me when I was stimulating, "Ooh, that's wonderful. It feels fine. You just leave it just like that. Don't do any more. I don't have the pain." And I told her that I couldn't leave the stimulator electrode in there because we didn't have the ability to do that during those years, that I would have to make a lesion, which I did. And she was relieved and continues to be relieved about 50% of her pain. That was about 20 years or more ago. I saw her several years ago, and I said, "Well, if you have any more trouble, we have a technique now that will really control it." And she said, "Well, I'm doing well enough now to..."
Oh, that's a very gratifying result. Oh, did you have many patients like that?
No, not with lesions, but with stimulation. We started stimulation about 10 years ago, and with stimulation, the relief is excellent. I'll say 75 to 100%.
And do they have to continue stimulating themselves every so often?
To begin with, they usually start by stimulating 3 or 4 times a day for 10 to 15 minutes. And as time goes on, they usually decrease the amount of stimulation they need. And over a period of 6 months, they may gradually attain a plateau at which they'll stimulate once a day or twice a day or once a week or 3 times a week.
And for how long do they have to leave the electrodes in place?
The electrode is left in permanently.
Permanently. Mm-hmm. And does this have any other effect upon them?
Yes. It's interesting in that you don't have any bad side effects from stimulation. And the other effects are alleviation of other symptoms that the patient may have in addition to the chronic pain. Even loss of sleep or impairment of sleep, which most of these patients have, is improved. Have patients
you mean that they're able to sleep after, rather than before, when they were, shall we say, unable to sleep at all because of the pain?
That's right. They'd be up half of the night. And the patients, some of the patients would say, "Well, they use it once a day. I use it at night, so I can get a good night's sleep."
That's their sleeping pill, isn't it?
That's right.
I see.
I also have one patient who has who says, "I stimulate in the morning in order to start a good day, and I stimulate at night to have a good night's sleep."
Well, now, do many of your patients have such results?
I'd say that 70, 80%.
Oh, that's very gratifying.
It's unbelievable. It really is. I have patients that, I have one patient, for example, who was in bed for a year. Started out with pudendal neuralgia. She also developed seizures that one could record, and had memory impairment, was on steroid. Her pituitary wasn't working at all when we saw her. And she had a stimulator in, finally got out of bed after a month and start walking.
Now, none of these stimulations modify the behavior of the individual.
Does not modify the behavior in an untoward way. If the patient's illness, whatever it is, modified the behavior from their original pre-morbid state, it will restore that pre-morbid behavior. And for example, one patient who had a head injury was unconscious for several months, at least 2 to 3, had a change in her behavior after the injury. She became very loquacious, very hyperactive. She has to have absence type of attacks, very severe headaches, couldn't sit still, very nervous, agitated, aggressive. Her children and husband wouldn't know what to expect when they entered the home at night or during the day. In contrast to that behavior, before she had her head injury, she was very quiet, very studious, read a great deal, and almost withdrawn, if you want to call it that, but worked as a waitress and got along.
Well, now, did you stimulate her?
She was on...
What was the result?
The result was excellent. She was on medication for about 10 years before I saw her, given by neurologists, psychiatrists, and myself. And finally got to where a neurologist just stopped all medication because she wasn't doing well and wanted to start from scratch, and she got much worse. Came back to see me, and I told her that we had this technique to control her pain, and if she wanted to try that. And she said she was ready to do anything. Following stimulation, it was just like night and day, to the point that after a year or two, she started to get a little worried. She was doing better, but at the same time was not as active as she was. She wasn't anxious and constantly going. And her husband kept telling her, well, this is your old self. And her family would tell her the same thing. And she finally has accepted that and is doing just as well as she did before the head injury. And it's interesting that that patient also had double vision at times, and at operation under local anesthesia. While I was evaluating the electrical stimulation, she all of a sudden let out a big yell. That was I had one of the greatest tormenting feelings I've ever had, just fright. I thought, what in the world happened? And I asked her, what's the matter? She says, I don't see double. Right there on the table.
This is while you were stimulating?
While I was stimulating. And I said, what do you mean? She said, well, I see one anesthetist. She actually was looking at the anesthetist at the time.
Well, now, what was the nature of her double vision, or diplopia? Were the images one on top of the other, or side by side, or one inside the other, or what?
Side by side.
Side by side?
Yes.
Mm-hmm. But she had no paresis of her internal or external recti.
On examination, the ophthalmologist couldn't find anything. All she had was a dilated pupil on the right side, which would dilate when she would get nervous, or when she was a little excited, or when her mind started fluttering around a little.
Was that associated with a greater amount of diplopia?
Yes, it would occur during that time, but not always, with the dilatation.
And
that's interesting. She used her pupil as an indicator of when to stimulate. When the pupils start dilating, she'd stimulate, come down, and she'd feel better.
And what happened to the pupil when she stimulated?
It came back to normal.
It constricted.
Yes. And it would react appropriately to light, too.
Well, now, to what do you attribute these excellent results that you've obtained?
To the attenuation of the pathologic discharge that we record in the thalamus.
Well, are the discharges lessened by the stimulation?
Yes, they're attenuated, very definitely. In fact, we use the EEG to monitor the level of stimulation that we apply.
Did you have something there to show us
Yes.
that effect?
This is a discharge at the depth, and that's a scalp propagation. When we stimulate, we attenuate this discharge and no longer see that type of activity.
And if you're recording on these patients, do the discharges become larger at the time that they're having more pain?
No, you cannot, we have not been able to relate a specific discharge to the pain itself. It seems to be a broader type of application. In terms of the major thing we can find is when we attenuate the abnormality, whatever it is, whether it be spike or slow wave, or, then the patient will show improvement. In fact, also with respect to thought processes, she also used these TV run games to determine whether or not she's needing stimulation, and finds that if she works on it, tries a game, and does not do well, she needs stimulation. So then she'll stimulate, and we'll go right through it. I had another patient who was interesting. He lost his job as a dental prosthesis worker in a dental lab, and stopped going to Millsaps because he shake and get nervous, and couldn't tolerate anymore. He had shock therapy a year before I saw him, which helped him for a while, but then he went back to where he was. And when he used his stimulator, he found that he could work his exams just like that. He had an IQ of 130, 135, and graduated with honors, and is now in computer work and math.
Well, now, do you want to make any further comments upon this fascinating study before we go on to another subject?
The only comment I would like to make is that we're dealing with pain problems and other problems, even memory or sleep, which are primarily based in a low threshold system, and that when they predominate, it's lack of surrounding inhibition.
Well, now, what evidence do you have that they have a low threshold system?
The major evidence is, number one, we have a discharge that we can record. Number two, in order to attenuate that discharge, we can use a stimulus which is inadequate to activate, say, the thalamic sensory relay nuclei, which are in the vicinity of the area. And you can attenuate the discharge sufficiently enough so that the person loses their pathologic behavioral state and are restored to a more normal condition. And over time, they don't need as much stimulation. It can be reduced.
Now, you've retired within the last few months, I understand.
Yeah.
Are you still able to do some of this work?
I'm not doing any more surgery. I'm retired from doing any surgery, and I'm working primarily on animals. And right now, the rat and trying to develop a little further the basis for what I call the brainstem multi-system syndrome that is generated from discharges which are located at the brainstem level. And in the rat, we find the same thing. And we have been correlating discharges with behaviors which are generated from the brainstem nuclei at that level locally, and also behaviors which are most likely due to implication of the cortex. And the reason I bring the cortex into it is that we are also implicating the catecholamine neurotransmitter generating cells at the brainstem level, which project to the prefrontal cortex. And we just completed some work in the rat showing that the dopamine, for example, in rats that have had brainstem perturbation is very markedly elevated in the prefrontal cortex. And dopac, its byproduct, is low or less than normal. And the other structure that has the same change is the caudate nucleus. Hippocampus, amygdala, hypothalamus do not have similar change. It's almost very selective from brainstem perturbation. Mm-hmm. And in my opinion is that schizophrenia, for example, in part may be generated from brainstem pathology, pathologic discharge systems that may occur.
Well, now, a number of people have done depth recordings from schizophrenics, but they've not found this type of discharge that you were referring to.
They have not been recording in this particular area.
Oh, I see.
They've been recording in the frontal cortex and in the frontal lobe at the orbital area of the frontal lobe. And I have also recorded discharges from the orbital frontal lobe area and in the amygdala in the past, before we used to use stimulation, and have made lesions, bilateral frontal orbitotomy and amygdalotomy, with improvement of some of these psychopathologic behaviors.
Well, I gather that your clinical work is now at an end, and you're largely working with animals.
It's not at an end with respect to working the patients up and collating the data and making reports on them. I still have a great many patients that I've been following now for several years, which I have not reported in the past because they have not gone long enough postoperatively. I just gave
this is a follow-up study.
Yes.
Yes. Well, now, tell us a little bit about your home life.
Oh, home life is wonderful. I'm a farmer at home. Get on a tractor and
How did you come to become a farmer?
Well, it primarily for two reasons. Number one, to raise a family out of the city and try to mold them in the way that you'd like to see them molded.
When did you get married? You weren't married when you came here, I understand.
No, I got married in 1960, and I arrived here in 1955.
What were your wife's interests?
My wife had an interest in teaching and was involved with teaching, and I think when we finally got married, she was with the Red Cross.
And subsequently?
She has been a housewife, raising 5 children, 4 boys and a girl. Patrick is farming. Paul is in agricultural school. Orlando is third-year surgery resident. Maria is first-year psychiatry resident. And Jack is a third-year medicine. This is my wife and myself.
And are they following in your footsteps?
No one is becoming a neurosurgeon except possibly one. He's in his 3rd year now. He's interested in neurology or neurophysiology and behavior.
Are the others in medicine as well?
The oldest boy is in medicine. He's in general surgery, doing his residency now. The daughter is in first-year psychiatry residency. And I have 2 farmers. One is farming at present, and the other is at school at State, which is, he's getting background in farming.
Well, now, how did you come to get interested in farming?
I had no choice when I decided to move out in the country, in a way, but because I wanted to keep my family busy, so to speak, and the best way to do it would be to have a farm and let them work on it, and that's what we did. We built our own feed system for the cattle and our own fences, and fed them in the morning and fed them at night, and raised the crops that we used to feed them too. And it was also a good educational experience for the children. And for me, the main thing was it got me away from the medical center and all the worries that go along with trying to develop a neurosurgical program as I wanted to develop. I had a great many irritating experiences during the process.
Do you still have your farm?
Yes.
And you're still farming it?
Yes, my son is farming it now.
I see. And what about your hobbies?
My hobbies, I like music in general, and
What instrument do you play?
I played the violin when I was 8, took lessons for several years, and then started piano. My uncle, who lived with us, was a musician. He played the piano and sang, and was quite good. I used to fall asleep hearing him play and sing. I think that's where I got my liking for that. And I also, and I took piano lessons all the way through. Even when I was at Baltimore, I took lessons there at the Peabody.
And do you still play the piano?
I haven't played in some time. And I also
have you been in an orchestra at all?
No, just as a student.
I see.
And I like art. And I actually was going to become a painter when I first started high school. Well, in junior high.
Watercolor or oil or?
Oil.
Oil.
I liked arts ever since I was a kid. I used to do a lot of drawing at home. In the winter, make drawings of snow on the trees and winter scenes.
You still do that?
No, I haven't done it very much. Last time I did something like that was several years ago when we went down the coast. Took some paints out and painted the coast. I enjoy it, though. It's very...
And do you play tennis or golf? Or
yes, play tennis. At Rochester, that was one of our main avenues of activity. Handball, ice skating. I love ice skating. I've always...
You can't do that out here, though, can you?
No, in fact, I still have my skates, though. I brought them down from Baltimore. And also golf. I love golf, and used to play a lot of golf at one time.
What's your handicap?
Well, it goes up and down.
See.
Right now it's about 125.
Let me ask you another rather philosophical question. You've been in neurosurgery now for quite a long time. You've seen a great deal of neurosurgeons. You've seen the trends in the field of neurosurgery. What do you think the future is?
Neurosurgery is sort of going in different directions, it seems. And it is a field that is being entered in by other disciplines, general surgeons, orthopedic surgeons, radiologists, and I think the field will still be maintained by trauma, brain tumors, and aneurysms to a certain extent. And finally, I think that one of the major activities that they can go after is behavior. I believe that with the present techniques, such as with stimulation, that we can modify behavior with this technique at present much more easily, much more specifically than we can with any drug or any conditioning type of therapy. One of the main deficits of treating many of the behaviors which are still filling our mental hospitals and so on is the inevitable broad effect that the drugs have upon the nervous system as a whole. When you pick on a drug to isolate a system, it invariably goes beyond that system, just like Haldol, for example, or on the other hand, dopaminergic drugs for Parkinson's. And we find a great many side effects. At present, we have the feasibility of combining drugs with local stimulation therapeutically.
And how effective is that? Or do you get side effects from it?
I have one patient in particular, which I just reported on a few months ago in New Orleans, who had an aneurysm, middle cerebral artery on the right side, ruptured. She had complex partial seizures, major motor seizures, diencephalic seizures, what I call, and she had an obsession of wanting to poison her husband, and was psychotic. She was admitted to the hospital, our mental hospital, on the average of twice a year for 10 years before I saw her. She had pain. She had photophobia, memory difficulty, spatial activity. Her husband had to lead her places. She didn't know where to go when she came to the hospital. We did a cranial resection, frontal and temporal lobe resection because of marked seizures. That took care of part of her complex partial seizure syndrome. It stopped her focal seizures and major motor seizures. It did not take care of the pain as I thought that probably it would, because she had a cyst there also. We did a ventricular shunt. That didn't help. We finally got to where she had a residual of pain and complex partial seizures. So we put an electrode in the thalamus on that side, saw the discharges, and treated those, and she was alleviated of those discharges and no longer has her perpetual recurrence of wanting to poison her husband. And it's interesting in that the husband, after this started to benefit her, said, well, now she loves that aggravator more than she loves me. He would call that stimulator that she was using an aggravator.
Mm-hmm.
And she's the one that said, I use it in the morning in order to get a good day, and then I use it at night in order to get a good night's sleep.
Well, now, tell me, are other centers using this technique of, we're going to say, medial thalamus stimulation?
There are other centers that have been using it and are still using it, but they're not using the 3 millimeter bare tip that I have been using. And in addition, they're not using the same criteria for placement of the electrode localization, as far as I know. They're automatically inserting an electrode around the periaqueductal gray or the periventricular system and stimulating there, because originally the relief of pain was found in animals by direct stimulation of that area.
But you're stimulating more rostrally than the periaqueductal gray.
That's right. And I'm stimulating in the area of the centromedianum nucleus and the midbrain reticular formation.
So that your effects would be quite different to those of the people who were doing periaqueductal gray stimulation.
Yes. I will not get the side effects, for example, that they get with eye movements.
Yeah.
And that is one of the worst things that occurs with periaqueductal gray. I felt that way when they were first doing it in that fashion, and have stayed away from it purposely. And as I've said, the reason I've stayed with the central medianum nucleus is because I had observed discharges there and felt that the discharges were actually contributing to the patient's syndrome. And it was the attenuation of those discharges that really benefited the patient.
Well, Dr. Andy, do you have any further thoughts about the future of neurosurgery, particularly with reference to these psychotic, psychoneurotic, or pain syndromes that you've been working with?
Yes, I believe that what we should try to do is develop a technique of either stimulation, or at present probably develop a technique of implanting a ball or a receptacle in a given area that will react with a systemically administered pill or drug that will work with it, and that way monitor the amount of, say, dopamine or Haldol or what have you that will be disseminated in that particular system.
Well, do you have any idea as to the drug or type of drug that would be effective in stimulating this central thalamic region?
One drug that I would try experimentally in animals, of course, to begin with, is Depakote, for example, because Depakote appears to be a drug that has a little more concentrated effect upon the brainstem activity than other parts of the brain, in contrast to, say, phenobarbital or Dilantin. And place a pellet, theoretically, in the brainstem directly, and note the effect of that drug on a given syndrome that is developed in that particular animal.
Do you have any other thoughts as to therapeutic goals that might be achieved in line with your theory?
I think that therapy for schizophrenia is definitely available, I think, right now.
Has anyone tried this, schizophrenia?
No, not that I know of.
Well, do you have any other comments that you'd like to make before we close this interview?
Yes, and that is one thing that we do not appreciate in relation to these various chronic behavioral syndromes is that, especially at the brainstem level, if you have a pathologic discharge that starts in one area, it may start with, say, a pain problem or a tick in the face. It'll slowly spread and implicate other cellular elements above and below that level, and thereby recruit other cells that are devoted to various biologic functions and systems alien to the first system that was involved to begin with. And after a period of several years, that you have a multiple system syndrome, as I call it. And the patient then is usually interpreted as being a crock or psychologically deranged, and is thrown back into the back wards. One factor which I have found very definite in relation to a patient's awareness of their behavior when it is of diencephalic origin, they are aware of most of what they do and don't do. They are aware of their aggression but cannot control it. The patients who have aggression, for example, of temporal lobe origin associated with complex partial seizures, are not aware of what they're doing. And that's the main difference between those two systems in terms of generation of aggressive behavior. The same thing holds true with hypersexuality.
What do you notice there?
Those patients who have, I have one patient who was hypersexual, and on stimulation, for pain, the pain was alleviated, but so was the hypersexuality. And there involved 2 people, and finally the stimulation was given up because of they didn't desire to have sexuality attenuated. And excuse me.
Well, were these people normal sexually afterwards, or completely asexual?
No, it was more normal state. And it's interesting in that I believe that the hypersexuality, for example, even of amygdala origin, or hyposexuality of amygdala origin, implicates diencephalon, and that you may have, say, from the amygdala, seizures that are long enough and prolonged sufficiently so that they become hyposexual. And once you get rid of those seizures, they return to a normal state. And at the same time, during their development of seizures, or at some point in the seizure, they may express hypersexuality in one situation and not in another. And we did a study some years ago on that in the cat. It showed very nicely what I call it was the rise and decay curve of hypersexuality in the cat.
And where were the lesions in that cat? Cats?
That was associated with discharges induced in the limbic system.
In the limbic.
That's right.
Yes. Well, that's very, very fascinating. If you have no other comments at this time, thank you very much. I'm sure that the association will be most grateful for the information that you've given us regarding your work. It's a fascinating field, and as you say, one which needs a great deal more exploration. Thank you very much indeed.
Thank you, Dr. Watson.